Yes, Bulldog.
All right. Okay, this afternoon we'll be talking about toxicology. We're not going to other realms of toxicology, which there are not a lot of branches like forensic toxicology, you have regulatory toxicology, you have regulatory toxicology, you have eco-toxicology. We're not going to go into that. We just simply be limiting ourselves into clinical toxicology, which deals with poisons that affect the human body. When we talk of okay, we start a little bit of environmental toxicology that hits close to home, especially the country. We first touch the DBCP or the bromochlorpropane, otherwise known or brand as fumazole or Nemegon, which is a nematicide. This is a nematicide used in banana plantations, and we see this in Mindanao, large swaths of land in Mindanao, South America, and even in some areas of India. And the problem with workers, banana work is exposed to your DBCP or your fumazole Nemegon is the observation that the males would eventually end up sterile. The problem with Nemagon is that in spite of the fact that the company that produce it would advise handlers to use protective clothing, do understand in tropical countries themselves, forcing these workers to wear PPE or protective clothing so do not get exposed unnecessarily to DBCP is rather and very uncomfortable, especially in the tropical sun. As a result of which, these banana workers are constantly exposed to DBCP, and as a result of which, a lot of them, or virtually most of those male workers, end up sterile. The problem is that the DBCP is an estrogen mimic, and even among women exposed to it, women banana workers would have an increased incidence of breast CA among them. All right. The estrogen mimetic activity of the DBCP is such that it atrophies the testes of males, and this has been shown even in experiments before the drug was brought out on the market. However, apparently these past regulations in third world countries desperate for exports of bananas, and somehow it passed licensing. It's been banned in 1979. Unfortunately, it still is present in third world countries. The unfortunate thing about DBCP is that when it affects males and females alike, there is no known antidote, and the damage is irreversible. As of now, in fact, we do not know whether the case filed by sterile banana workers in Mindanao, Belmont, and Dole workers is still progressing, if it has been settled, because indeed of sterility of the male workers, and we see a high incidence among banana workers, women banana workers. All right. The other thing we'd like to touch on as far as environmental poisoning in a country is your so-called red tide, otherwise known by the generic name harmful algal blooms. And this would usually be due to dinoflagellates of the Grignolax family, especially when they dominate the plankton or benthic population. We say plankton, they're floating around. Benthic is the bottom of the aquatic body wall, the aquatic bodies, okay? Red tide, which is red tide, they indicate harmful algal bloom or HABs, but they're not necessarily of the color indicated. Some Grignolos will give off yellow or brown or green or blue, even white colors. And so red tide is basically just a subclass of your so-called harmful algal blooms. Now, only filter feeders like your shellfish, your bivalves, your mollusks, your shellfish would pose risk to humans because the concentration of saxitoxin, which is the active neurotoxin present is secreted rather than your Grignol. So these that gets trapped in the meat of your shellfish bioflavonoids when they ingest these dinoflagellates. Your fish also concentrates the toxin, but in the viscera. However, because when we eat fish, we usually remove the intestines, we usually do not get poisoned. And if the concentration of toxin in the viscera, in the intestine of the fish gets too high for them, they too are supposed to get poisoned as well. The problem with toxin is that it is rather heat stable. There's no amount of cooking, whether you boil them, you broil them, you bake them, you fry them. It's heat stable, which means that even if it is thoroughly cooked, the toxin will still express itself. Toxin blocks your neuronal sodium channel, and therefore action potential is not transmitted across your neuromuscular junction, as a result of which sensory and motor disturbances are felt by the patient in the form of numbness, tingling, dizziness, and if the toxins affect the neuromuscular junction, then you have signs and symptoms of paralysis. And the autonomic response of the heartbeat is initially tachycardia, even if the paralysis of your active muscles will involve dyslexia, dysphagia, difficulty breathing, headaches, even abdominal pains, vomiting, and diarrhea. Unfortunately, for paralytic shellfish poisoning, there is no antidote, and the treatment is largely supportive. Fluid therapy to maintain circulation, and if there is respiratory paralysis, then ventilator support. We may have to put this patient on mechanical ventilators if the poisoning is rather severe. All right. Other areas of environmental poisoning, marine animals envenomation, bee stings or arthropod stings, I'm not going to cover. Okay. Hopefully, this has been covered in your first aid class when you were first year. All right. Okay, so this is a picture of yourself with red tide. This is literally red tide. All right. And you also have fish kill that accompany them usually. Apparently because one, either the fish themselves have ingested a lot of the toxin, or two, the algal bloom deprives them of the oxygen in the water. That's why they literally asphyxiate and they die. All right, let's go to the topic of poisoning. Now, in our country especially, the true incidence of poisoning is not quite known. This is also true among other countries, even first world countries. And the reason to that is one, it's not usually, perhaps because it's not a commercially viable, quote unquote, area of medicine. One, it's uncommon, and the manufacture of antidotes, because of the relatively small population that goes into toxic exposure to medications and other substances, are very small. So the proceeds from selling antidotes is not usually that so-called commercially viable. So when you talk of poisoning, you're talking of illness due to exposure to a toxic substance. And the more common ones that we encounter are recreational drugs, intoxications, overdosages, exposure to certain occupational and environmental toxins. It could be homicide or suicide attempts, or accidental ingestions. And recently, with the wars ongoing in Syria, Iran, for instance, there have been reports of chemical weapons, or in Japan, the use of sarin gas in the train several years ago have been brought to light. We are not going to talk to that anyway. So, when you have a patient known to the poisoning, the approach to management will always be, the priority will always be stabilization of the patient, which means you secure the airway, make sure the patient is breathing, make sure that the vital signs of the patient, cardiovascular wise, is okay. And then you go to taking a look at, well, what is the disability of this patient? We're talking CNS disability here. Is the patient going to seizures? Is the patient sensorium down? What is the GCS score of the patient? E stands for elimination of the poison. F stands for fluid and electrolytes, and finally the antidote, if available. And if available, it should be administered promptly. Obviously, there are a lot of stumbling blocks in the management of poisoning. Sometimes you have patients who are either mentally challenged or with underlying psychiatric conditions, and the history from themselves may not be that reliable, or sometimes the patient may just be found, for instance, either seizing or depressed sensorium, or agitated or with behavioral changes. And it may take some time before of investigation before you realize that the patient is a toxicologic patient. And this is especially true in high toxicity ingestion. Your priority would always be stabilization, the A to D cardiorespiratory stabilization. Now, in a patient who is immediately known to have ingested a toxic substance for as long as the ingestion is within 1 hour, or in a patient whose ingestion is unknown and there are no telltale signs of, um, of, of, of any contraindication to uh, gastrointestinal decontamination. We're talking gastric lavage, activated charcoal administration, or NGP. Then gastric lavage is primarily done to try to recover as much of the ingested substance in the stomach as possible and therefore mitigate the effect of the poisons. The gastric lavage may be with or without activated charcoal. The activated charcoal is the substance that absorbs all the poisons, the intestinal contents, and therefore prevents whatever toxin there is in the gastrointestinal tract to be absorbed systemically. And if, as I mentioned, the antidote is available and the poison is known, then the antidote should be administered promptly. So when we talk of toxicology, we're talking of adverse effects of a toxicant or poison in a living organism. And when we talk of adverse effect, we're talking of changes from the normal homeostasis of an individual's existence. This, of course, is dependent on the concentration or the dose of the active compound, and the target site and the exposure of the human being, of humans, to that particular toxicant. And when you say poison or toxicant, we are talking of any substance that is capable of producing a disturbance in the homeostasis of an individual person, especially its deleterious effects. And so when you talk of poisoning, we're dealing particularly with clinical toxicology. We're talking of overdoses of drugs, medications, or biological substances, or the administration of the wrong substance given or taken in error. Toxicology does not cover the expected adverse effects, hypersensitivity reactions of substances, of the correct substances properly administered. So that, for instance, if you take diphenhydramine because you have allergies and you feel drowsy the whole day, that is not a concern of toxicology. That is, in fact, an expected side effect of your diphenhydramine as the first generation of antihistamine. Okay? And the toxicologists need not be called because you look like a wilted vegetable, all there. All right, Paracelsus is supposed to be the recognized father of modern toxicology. And as early as the 15th century, he stated, there is nothing in this world that is not poisonous. It's just a matter of dose. And among the medications that we're going to use, that we are using, is the dose, the amount ingested or exposed to that differentiates whether it's a poison or a remedy or a treatment. So, for instance, everyday substances that we use, like your sugars, at a healthy 50 of 30 grams per kilogram. Ethanol, 13.7, that's about 1.5 to 2 bottles of vodka. Water has a recognized LD50 of slightly greater than 80 gram per kilogram. Now, why would somebody be taking 80 liters per kilogram? That's about what? For a 50 kilogram person, that's that's more than 40 liters. And yes, we do encounter this in patients with diabetes insipidus, where patients may drink water. They first will be so intense that they're so desperate they will drink from the flower vases, even from toilet bowls. Okay? Now, even oxygen that we breathe every day can be toxic at 50% FiO2, and if given for more than 48 hours. And this is one of our findings in patients with respiratory failure, hypoxic respiratory failure. We want the PO2 to go up, the partial pressure of oxygen in the arteries to go up. At the same time that we balance it, make sure that the patient is given the lowest possible concentration of oxygen so as not to activate reactive oxygen species in the lungs that in themselves may cause massive inflammation. Now, what if you do not know the patient ingested? In cases where patients, for instance, are seen unconscious or sneezing or manifesting weird behavior, and they are suspected of having ingested something poisonous or have overdosed, and nobody can provide a decent history. We rely on toxidromes. And toxidromes are nothing more than signs of intoxications. We're talking signs, not symptoms, kasi wala kang makuha sa natinong history. And we usually rely on the autonomic effects of the toxicant. And so we take a look at the eyes, the skin, the secretions, the vital signs, and these findings would allow narrowing the differential diagnosis of what poison the patient has ingested. And your so-called anticholinergic toxidrome, characteristic of patients who overdose with first-generation antihistamines like diphenhydramine, dimenhydrine, your antipsychotics, especially the older ones, the phenothiazine, the propromazine, or your cyclic antidepressant, your amitriptyline, and your carbamazepines. The anticholinergic toxidrome will manifest itself, and this is characterized by tachycardia, elevated blood pressure. The patient may go into tachyarrhythmia. The respiratory rate would be normal to high. Patient may be hyperventility or not at all. The patient is flushed and the temperature is high. The pupils are low. Patients are dilated. The pupils are dilated. The skin and the secretions are unusually dry. And so I'm not sure if this has been restated to you in pharmacology. Patients with the anticholinergic toxidromes are mad as a hatter because they're usually agitated as well. They're blind as a bat because of the intense miniasis, the dilation of the pupils. They're hot as hell. The temperature is high. They're flushed. That's why they're as red as a beet. They're dry as a bone because of the anticholinergic effects. And severe, they could be seizing like a squirrel, or they may be in agitation, or in severe cases, they may be in fact going into seizures. All right? The opposite end of the spectrum are patients who manifest your so-called cholinergic toxidromes, and these are the patients who would have overdosed or been exposed to organophosphate poisoning. We are an agricultural country, and I'm sure you're familiar with malathayo and palathayo. These are the widespread agricultural insecticides that we use on our vegetable growers, fruit growers, even rice growers, right? And exposure to these chemicals, organophosphates, would give you the following sets of signs. There will be bradycardia, your BP could be normal or low. The heart rate will always be on the bradycardic side. The respiratory rate, the temperature could be normal to low. In contrast to anticholinergic toxidrome, the pupils of these patients are pinpoint, myopic. Because of the cholinergic effect the autonomic nervous system, these patients are drenched with secretions and copious. We talk of lacrimation, broncholia, rhinorrhea, even emesis, diarrhea, etc. Okay? Now, patients who go to organophosphate poisoning has this peculiar smell of kerosene and garlic combined, so that if one patient enters the emergency room having had ingested malathayo or palathayo, you will usually know because the whole room will smell of that characteristic kerosene plus garlic smell. And so patients with cholinergic toxic syndrome, you have your mnemonic sludge. Again, highlighting the autonomic effects of your cholinergic agents, salivation, lacrimation, urination, diarrhea, GI dysmotility, and they could even go for vomiting, or yourself with dumbbells, which are basically the same as sludge, except that here you added the pinpoint pupils in the M and the bradycardia in the B, okay? Second B. Patients may also overdose with sedative or hypnotic agents. And so the toxic syndrome associated with these overdoses is, of course, somnolence or stupor, and sometimes loss of air protection if the dose ingested is rather very high, and even respiratory depression. The autonomic effects would usually be minimal because of congestions. Benzodiazepines, even at high doses, are rarely fatal. What they get, it gets fatal if it's usually combined, if your CNS depressants are combined with other agents like benzodiazepine and alcohol, propofol. Think of Whitney Houston, Elvis Presley, Michael Jackson, River Phoenix. They did not die from a single overdose of an agent. They usually die because of the combination effects of a lot of recreational drugs. We're talking benzodiazepine, we're talking propofol, we're talking cocaine, we're talking amphetamines, etc. The autonomic effects of CNS depressants and CNS stimulants would usually cancel out each other, and so the more prominent manifestation would be whether or not the drug would cross the blood-brain barrier, and so patients with sedative hypnotic toxic syndrome, the prominent manifestation would be CNS depression. Opioid toxic syndrome are just like the sedative hypnotic toxic syndromes, except that in patients who took narcotics, opioids, miosis or pinpoint pupils is universally present. We're talking of morphine overdosage, codeine, fentanyl, and the congeners. All right? Now, the last is your symptomatic toxic syndrome. These are patients who would usually come to the emergency room with a history of intake of sympathomimetics. These are sympathetic nervous system active agents, and these are examples of which are your ephedrine, phenylephrine, also phenylpropanolamin, which are ingredients in your Combs medication, right? Because they are very potent decongestants that have alpha and beta stimulating effects. That's why you see these signs here. It accelerates the heart rate, the beat is high, the rhythm is rapid, the heart rate is rapid, and they may even go into tachyarrhythmia. We're talking fibrillation, atrial supraventricular tachycardia, etc. Although the respiratory temperature could be normal, the pupils will always be dilated. The skin will be normal to diaphoretic, the secretions would usually be normal. All right? Among patients with amphetamines, the symptomatic effects would be so intense that the patient would be agitated. Sometimes they could go to seizures as well. Cocaine, monoamine oxidase inhibitors, tricyclic antidepressants also do have symptomatic symptoms. So in summary, excuse me, here you are, and you get the screenshot of this, so I don't have to repeat it again. The symptomatic, mimetic, and anticholinergic agents have similar manifestations. The difference is that your symptomatic agent poisoning patient is diaphoretic, even as both of them can be agitated. At the other end of the spectrum, your cholinergic poisoning patient will have depressed heart rate and blood pressure. The respiratory rate will be down, the temperature is down, but the pupils here will be pinpoint. If you compare sedative, hypnotic, and opioids, they have similar manifestation, except of course that with opioids, the manifestations are way much more intense. And as I said earlier, you will always see pinpoint pupils in patients with opioid poisoning. Now, when you talk about dose as far as toxicology is concerned, we are of course talking about the amount of the chemical or substance entering the body. And is usually expressed as milligrams per kilogram, and it's also the unit we express when we say that, oh, this particular drug has a toxic level or an LD50 of this milligram per kilogram, all right? And the dose, of course, is also dependent upon the environmental concentration or dose exposure, the properties of the toxicant. There are toxicants whose effects are immediate. There are toxicants whose toxic effects may be delayed for several hours, several days. And in patients who overdose with thyroxine, for instance, it may take a month for the manifestation, for the toxic manifestation to last. The duration of exposure and the exposure pathway. Of course, the onset of toxic effects will be much faster if the toxin is administered intravenously, directly into the systemic circulation, followed by inhalation, followed by intraperitoneal route, IM route, PO, peroral, and topical. Topical being the weakest and slowest slowest route of entry and the slowest route to give you toxic effects. Do understand, however, that there are certain poisons that penetrate the skin quite readily. Malathion and parathion are one of them. The toxic response could either be local or systemic. It may target particular organs of the body or it could be widespread. Example of which is your arsenic, for instance. It may target the hair, the skin, and the kidneys. While allergies, severe allergies like severe anaphylactic reaction, for instance, is of course systemic. It could be reversible versus irreversible. Depending on the toxin ingested, the effect could be immediate or delayed, as I've stated with my previous example, or be graded versus quantum. When you say graded, the same organ is targeted, it's just getting severe, more intense as you increase the dose, but when you say quantum, there's only a particular point where the dose is reached, and the patient below that, the patient probably have no response, but beyond that, the patient would have lab symptoms or worse, die. Now, you have seen the sigmoid curve, and this is a literally universal manifestation of all the drugs we ingest. And this curve is, as far as toxicology is concerned, is divided into four. 0 to 1 is the dose of the exposure at which there is no adverse effect, or the no adverse effect level. At 2 to 3 of the linear range is the 25th and the 75th segment of the graph. In other words, if that graph is, if I'm going to divide that graph into 4 segments, one here, there, again here, the middle one is your so-called, you have a linear slope of the graph. In other words, if you're going to translate this into therapeutics, that means this is the dose of the drug that you're going to give, where the effect that you see increases as you increase the dose. All right? Now, here, this is an example of a therapeutic drug being given. As I've said, the 25 to 75 response is your therapeutic dose, okay, the range. And basically, what is done here is you divide the graph into 4 segments. Here, this is 0 to 25, this is 25 to 50, that's 25 to 75, and that's 75 to 100. The middle part of that range, the middle part of that graph, has a linear slope, which means that given the particular dose, as you increase it, the therapeutic effect, this is a therapeutic drug for that matter, will also increase as you increase the dose. Okay? So this is what we call your so-called therapeutic window, the range of dose where you get the benefit of what you're looking for. Now, if you go side by, if you get that graph and place that side by side with the same drug, but this toxic or lethal particular concentration, then you have this, okay? So that's your desired effect. This is your overdose graph. And you see that in this particular instance here, this is semi-logarithmic, by the way. And so we talk of your so-called LD50 and your ED50. This is therapeutic dose, this is your poisonous dose, and we talk of When you say ED50, that means the dose at which you have 50% of your test population have the favorable response. But if you talk of LD50, that means the dose of the toxin, or the poison, that will kill 50% of the test population. You do not do this, of course, in humans. These are usually extrapolated from animal studies. Okay? Now, there are certain drugs that have so-called very narrow therapeutic window, and theophylline is an example of that. And that is also the reason why theophylline is getting less and less popular, and hopefully one day it might even disappear completely from the market. Here's what happens. When you give theophylline, which is supposed to be a bronchodilator, a phosphodiesterase inhibitor, at low dose, it causes bronchodilation. However, as you increase the dose, your patient will develop diarrhea. That's an adverse effect. If the dose is increased further, oh, by the way, previously, 2 decades ago, there was the so-called aminophylline, which is the intravenous form of theophylline, the intravenous equivalent, and that's the one we use to infuse our patients who are in acute asthmatic attacks. As you increase the dose, the patient will go to tachycardia and dyspnea. If that is still, if you do not stop the medication, then the patient will go to motor metabolic side effects, especially hypokalemia. Beyond that, if you increase the dose further, the patient will go to seizure. Beyond that, the patient will go to coma and death. In other words, you are in the lower part of the graph here. We said that in an ideal drug, you're supposed to receive the therapeutic dose somewhere here, because you increase the beneficial effect of the drug as you increase the dose. But in the case of theophylline, it has a very narrow therapeutic window, because you have to give it very low, beyond which you already have your adverse effects. All right? This is the graph I showed you earlier, comparing the ED50 and the LD50. The LD50-ED50 ratio reflects how safe a drug is. If the LD50 to ED50 ratio is about 10 or higher, then the drug is deemed safe. In other words, if you're taking a drug, for instance, for a particular condition, you take it at 5 milligrams per kilogram, and it will take 50 milligrams per kilogram of that drug to kill you, that is considered a safe drug, because you're in a wide leeway of those ranges to increase or decrease your dose depending on the response, provided you don't have the toxic effects. So when you talk about therapeutic index, we said the ratio, LD50 and ED50. And when you say therapeutic windows, we said it was narrow for theophylline. We're talking of the dose range between the minimum effective dose and the minimum toxic dose. So you see in patients who are in theophylline, for instance, no. Beyond 20 micrograms per kilogram or per liter of blood, you already have your adverse effects in the form of GAT. The patient could feel nauseous, the patient could do vomiting, etc. Okay? And when we talk of toxins or poisons, the measure of toxicity we express as either the LD50, expressed in milligram per kilogram. If it is gas or liquid, then we talk of LC, the lethal concentration of 50, the concentration that will kill 50% of test animals. Okay? Or if you're talking about gas, then we usually either take it as milligrams per liter or parts per million. The toxicity of drugs may not only be from death, but also teratogenicity. These are defects in the next generation. Carcinogenicity, the ability to cause cancer, think of atomic bomb, nuclear bomb victims of Hiroshima and Nagasaki. Mutagenicity, or the ability to cause heritable change in the DNA. Think of DBCP, where even the offsprings, main offsprings of patients exposed to DBCP were born sterile. Okay? Now, if you take a look at workers exposed in the workplace, the International Labour Organization has classified and labeled certain substances and chemicals into different categories. Note that as you go from lower to higher category, the less toxic that particular substance becomes. Category 1 is the most dangerous because if you notice, you only need a very small dose for toxicity to set in or even death. All right? Category 4 requires a much higher dose for toxicity to appear. And so category 1 are the most toxic of the chemicals to which your workers can be exposed. Now, there are different poisons with different LD50s. Ethanol, as I mentioned, is about 10,000 milligram per kilogram. Salt is 4 grams per kilogram. Ferrous sulfate is dangerous because sometimes most common backstory would be a pregnant woman in the first trimester discovers that her boyfriend is in fact married, and so they overdose with ferrous sulfate. Because ferrous sulfate is basically universally prescribed to pregnant women. Eumorphic sulfate, strychnine, nicotine, black widow, furane. These are all poisons, by the way. But think about your botulinum toxin. We use it now as Botox. Ladies, if you want to Botox eventually in your life, iron out those wrinkles in your faces, just make sure that the one injecting it does not inject it directly to a capillary or vein. Because you know how toxic that is. Look at that. 1/1000 of a milligram is enough per kilogram is enough to kill you. And you're familiar with the skull and crossbones of patients of chemicals and substances that are highly toxic or highly poisonous. Okay? And this too has been advocated internationally, especially by the ILO, and it also applies in our household chemicals that we're using. I'm sure some of you are still using hydrochloric acid, 10%, otherwise known as your muriatic acid. Okay? And patients in motor shops were using sulfuric acid to refine the lead acid batch, for instance. These acids are quite concentrated, and so there has to be a skull and crossbones signage on the packaging or outside the containers. All right? All right, so we also classify drugs according to the FDA classification. Just remember that if the drug is labeled FDA Class A, that means that drug is safe even for pregnant women in the first trimester. Okay? B, C, D are classification of drugs, the old classification of drugs that that are less safe than patients that in class A. So in B, for instance, you have animal studies have not shown the risk to show in Jesus. Animal studies have not shown risk to the fetus, and there are no equivalent studies in humans because you do not prospectively study certain chemicals or drugs among pregnant women. It simply is not ethical. Okay? C, for instance, are a little more dangerous because animal studies don't show adverse effects on the fetus. D, definite positive evidence of human fetal risk. X are those patients who, by all means, if there are other options, are not usually used in humans unless you take into consideration the cost benefit. Okay? We're talking of chemotherapy, the whole chemotherapeutic agents. Your N means the drug is not classified, and usually they just use for compassionate use. Included here were previous medications that we used during the COVID pandemic. At which time nobody knew if it's going to work or not, but we're going to try it anyway because there's nothing to lose, and we didn't know what to give these patients, these dying patients. Since 2015, however, the labeling of drugs and the safety measures and the safety status rather have been modified, and this is now result of PLLR labeling, and it's supposed to have been in place since 2015. The old five-letter system has been discouraged to be used, and the new labeling system now allows better patient-specific counseling. The problem is, if you're going to use this, you have to read a lot of your drug literature. Let me tell you why. The drug literature is supposed to, the drug literature that accompanies every packaging of drugs is supposed to include the effects of pregnancy exposure, you're supposed to report this to pregnancy exposure registry, especially about pregnant women, for instance, who took the medicines and they did not know they were pregnant at the time. The clinical consideration and the consideration of the data accumulated for that particular drug, especially the effect of lactation. And this time, if you notice, the old classification only took a look at the effect on fetus and pregnant women. The new labeling now considers the effect of it on babies, lactation particularly, and its impact on the fertility of not only females but males. Okay? Example, among patients who are taking dutasteride or finasteride, which are anti-testosterone agents that we use for patients with BPH. If you have read the drug literature, women are not advised to go pregnant, and males are not supposed to have their partners pregnant within the next 6 months because of the anti-testosterone effect. So in that particular aspect, not only are the impact on fertility of females, but the impact of the fertility on males are also being considered. And that too has to be reviewed in the drug literature of a particular drug. Now, exposure to the toxin, we talk about the acute, subchronic, or chronic. When we say chronic, that means repeated exposure over a span of 3 months. When we say subchronic, you have repeated exposure 3 months or less. When we say subacute, within a month, again, repeated exposures. And when we say acute, less than 24 hours, usually one or repeated exposure provided it's within the 24 hours. Because over time, the amount of chemicals of poison in the body can accumulate, it can overwhelm the defenses of the body, it can overwhelm the excretory capacity of the body to get rid of the poison. Now, in general, here's what we do for patients who present with poisoning. Again, the ABCD is here. We're going to discuss it in more detail. If you have to address the airway of the patient, to secure the airway of the patient, so the patient is barely breathing or not breathing at all. Just like you've been taught in BCLS, BLS, and ACLS, you make sure that before you secure the airway, you remove the obstruction, you remove the dentures, you suction vigorously if you're in the setting of the emergency room. In patients, for instance, where there may be a risk of cervical or cranial fracture, we're talking of patients who jumped out of a building because it was on fire, or a patient who finished 20 steps of stairs in just 2 steps and fell on the ground. You do not know this patient has cervical fracture, and especially if these patients are conscious of acute respiratory failure, you have to secure not only the airway, but in so doing, you also make sure that there is no cervical fracture. You do not want that patient to dissect his or her spinal cord at the cervical area, because that could paralyze the rest of the body from that nerve level down, spinal nerve level down. Once you secure the airways, the breathing has to be assured. Take a look at the oxygenation of the patient if it is adequate. Give oxygen if the patient is hypoxemic. Your oximeter are now quite ubiquitous. It has become a standard part of your physical examination tools, in addition to your stethoscope, your sphygmomanometer. And if the patient needs mechanical ventilation, then your patient may have to be intubated and put to the machine. Circulation has to be assured. IV insertion is usually mandatory in patients with poisoning, especially if their sensorium is not that good. We usually use diphylalisis, lactated ringers, or acetated ringers. And if the patient is still hypotensive, we place this patient on Trendelenburg on top of the fluid resuscitation. If that still does not increase the blood pressure of the patient, if the patient is still hypotensive, that's the time we put in our inotropes, norepinephrine, dobutamine, dopamine, etc. Even vasopressin sometimes. Okay, D is for disability, but especially referring to CNS. Okay, is the patient seizing? Is the patient sensorially depressed? Is the patient agitated, etc.? This is where the D of your ABCD portion becomes here. You're familiar with the Glasgow Coma Scale? Do take note that If the patient is non-responsive, is in deep coma, the GCS score should be no lower than 3. If there's no 0, the score is systemic. Now, among patients with seizures, especially in our country, seizures could usually be due to isoniazid overdose, to be cerebral hypoxia, especially if the patient has been not breathing for a long time and the return of spontaneous circulation is restored to emergency room. If the brain has been effectively hypoxemic, be deprived of oxygen for 10 minutes or more, they could go so-called hypoxic encephalopathy manifested by intractable seizure. The patient can also go to seizure if your patient is hypoglycemic or can have the muscle spasm as well. With patients who are withdrawing from alcohol, opiates, barbiturates, benzodiazepines, can also go into seizures, as well as those patients taking medication that reduces the threshold of seizure. Think theophylline, for instance, because one of the toxic effects of the theophylline is seizure. So if the patient has a history of seizure, we usually make sure that theophylline, even if indicated, is not given to them. Now, the drug of choice of patients going to seizure, regardless of the cause, will still be diazepam. Note that diazepam may only be given intravenously. You do not give it IV, you do not give it subcutaneously, you give it intradermally. Why? Because systemic administration of diazepam, other than giving it intravenously, is not advised because it is erratically absorbed intramuscularly, for instance. Okay? Most seizures due to INH, organophosphate, salicylates, tricyclic antidepressants, methylamic acid, and NSAIDs, ethylene glycol, and theophylline. Okay? Now, the characteristic of seizures, especially with INH seizures from INH overdose, is notorious for their inability to respond to repeated doses of diazepam. So if you have given as much as 10, 20, 30, or even 40 milligrams of diazepam, and your patient is still seizing, the very first agent of overdose that you should consider would be isoniazid. Okay? In some other toxicological bodies, associations, other than your GCS, they might use other scales and take a look at whether or not the patient is stimulated or depressed. And so they have the 1, 2, 3, 4 scoring system. If the patient is stimulated, yung mga nakasyamu, halimbawa, it could be just as simple as anxious to agitation to delirious to frank seizure and cardiovascular collapse. The same thing is true in patients presenting in the emergency room. CNS are depressed. They could be awake but lethargic. They could respond to pain but not to voice. Again, these have equivalents in your GCS scoring system. They could be responsive to pain or they could be totally unresponsive to all stimuli, and these are the patients whom you may have to intubate immediately. Okay? Now, if you take a look at the individual manifestation, take a look at the pupils, for instance. Poisoning that manifests with meiosis includes poisoning from your opiates, your organophosphates, your brain modifier, your carbonates, and your anticholinergics. Okay? Yung old insecticides natin sa bayo, Sheltox, your Raid, your Bicor, 10 years ago, they contained carbamates, which have the same effects as your organophosphates. Now, our insecticide or household insecticides, even herbicidal agents, are pyrethroid derivatives. These are, if you take a look at the insecticide bottles now, insecticide sprays, they usually will contain active ingredients, which usually be in the form of compounds, chemicals that contains PHRIN, free in their generic names. And these are pyrethroid. It could be pyrethrin, what else? Ethylphenylphthalein, These are pyrethroid derivatives. These are extracts of alkaloids from chrysanthemum that are potent um, insecticides. All right. And the beauty of it is that although it is extremely toxic to insects, its binding ability to human neuromuscular system is 1,250 times less than it is among insects. So it is much more toxic. It's 1,000 for the same dose. It's 1,250 times more toxic to insects than it is to humans. Midriasis, you see that in patients in alcohol intoxication, patients who ingested anticholinergics, patients who were in washamu, okay, patients who may have overdosed with the beta blockers. All right. If you find a patient who are having electrolyte metabolic problems, these are also the differential diagnosis. Suppose that the initial blood draw, your patient has hypokalemia, and you think of agents that pushes the potassium into the cells. We're talking theophylline. We're talking your oral bronchodilators, okay? Because these agents stimulates the sodium potassium pump, and so a lot of your potassium is pushed into the intracellular space. And if you draw blood, which is in the extracellular space, your potassium is very, very low. You would also see this in patients who are into forced alkaline diuresis because of the potassium loss in urine. When we do this, in patients who go into rhabdomyolysis, for patient has a seizure, the muscles could break up, rhabdomyolysis, and these muscles release a lot of potassium into the blood. Now, your myoglobin that is released could crystallize and remain undissolved as they pass through your renal tubules, and these myoglobins could block these tubules, the renal tubules. So what we do, we try to alkalinize the urine so that your myoglobin still remains in solution and passes through instead of causing renal failure when your precipitated myoglobin blocks the renal tubule. You will also see this in corticosteroid use. Why? Because in your corticosteroid use, you retain a lot of sodium, but you excrete a lot of potassium. Okay? The treatment, of course, is to replace the potassium. If the patient can take oral, if the patient can take oral, if the patient is not on a pill, if the patient is eating, then you may opt to give your patients potassium tablets instead. How about the opposite then? Hyperkalemia. Hyperkalemia is seen in digitalis toxicity, patients who have overdose with beta blockers, and in contrast to the previous poisoning were characterized by hypokalemia, the agents involved here inhibits the sodium potassium pump, and so potassium continue to be pushed into the extracellular fluid space. And this you also see in patients who are taking or have overdosed with ACE inhibitor. Hyperkalemia is also seen in patients with carbon monoxide power poisoning, cyanide poisoning, because in these particular instances, you lack the ATP to fuel the pump, the functioning of the sodium potassium pump. As I mentioned earlier, rhabdomyolysis could release a hell lot of potassium into the system, and so you will have hyperkalemia. Or patients who are taking potassium-sparing diuretics, think triamcinolone, think spironolactone, all right? Especially if they use this or they take these medications without doctor's advice. If you have cardiac compromise characterized by peaked T waves in your ECG, you may want to intervene because hyperkalemia can cause cardiac standstill, all right? And you remember some of in countries, for instance, where lethal injection is legal. This is usually the last agent they use to push the heart into cardiac standstill. Okay, the first sedate the patient, then they paralyze the patient, then they give potassium to stop the heart. Now, the cardiac compromise is a threat. Again, as I mentioned, if you see peak T waves in your ECG, then you have to push your potassium back the intracellular space, and you do that by giving your patient your glucose insulin cocktail, okay? Or to preserve the contractility of the heart, you give your patient calcium gluconate, intravenously, of course, okay? How about if you present to the patient with hypothermia? Posible dito sa Pilipinas, init-init, yes. I've seen one patient working in a cold storage facility. These are people who bring this gargantuan tuna and blue market into the cold storage. The guy slipped, fell, lost consciousness, and brought to the emergency room with body temperature about 32, 33. Okay? So to say hypothermia, we take the rectal temperature of the patient. Hindi axillary, rectal, because this is the inner temperature, the core temperature of the body. And you see this also in patients with ethanol, especially when exposed to a cold environment, tricyclic antidepressant, or patients who have overdose with barbiturates. Okay? You do not place this patient in a warm tub. Okay? You don't. You don't. So measures to raise the body temperature are quite harmful. So what you do is try to start to improve the sensorium by bringing back the temperature by conservative means, thermal blankets, thick blankets, etc. Okay? You may also see this in patients with overdoses of oral hypoglycemics, phenothiazines are the old antipsychotics, and sedative hypnotics. Bakit natin lumalabas itong mga phenothiazines na ito? Well, we are third world countries. There we still have a lot of psychiatric patients who are financially constrained. And so the new use of SSI, for instance, typical antipsychotics, are quite expensive compared to the older ones. And so don't be surprised if these patients are not on ketamine, they're not on olanzapine, but they are on haloperidol, they are on promazine, which are very old antipsychotic agents, but definitely are way, way much cheaper than newer agents. What if the patient is in hyperthermia? A hyperthermic patient has a metabolic mechanism that is in red. Okay? Nagre-revolusyon kanyang makina. And these are the patients whose metabolic rate has to be brought down rapidly. These are the patients who you might have to plunk in cold water. So if you have this patient, we usually do is roll them in thick blankets and pour cold water in the blanket to bring the temperature down fast. You see this in patients who use shabu, atropine, salicylate toxicity, because salicylate, although antipyretic, it can disrupt the thermoregulating centers of the brain. Okay? And so these patients are given an ice bath or before targeting the menopause. Okay? By the way, you also see this in patients with poisoning from antihistamines, especially the first generation of histamines, isoniazid, phenytoin, salicylate, sulfonamides, and even theophylline toxicity. What if you find a patient who you know has ingested poison and is hypoglycemic? And these are differential diagnoses. The patient could have been into an alcohol binge and has exhausted his glycogen stores in the liver. So we go into hypoglycemia. What you do in these patients is very common on ethanol intoxication of patients who go to ethanol binging. You give your patient B50 to give your patient to bring up your glucose levels to normal. You also give the thiamine, so the patient does not develop the so-called Frederick's encephalopathy. Okay? And also, of course, stands for the antidote, finding the antidote. Be mindful again, not all antidotes are present, even in first world countries. They have your poison center, they may have your national poison control center, but then it's not necessarily accessible. They may fly a helicopter In the States, for instance, you have the National Poison Control Center, you call them, and you have this patient bitten by the rattlesnake, the antivenom usually still be transported. You do not stop these antidotes readily in the hospital. Okay, so in poisoning, the initial clinical evaluation goes back to basic. Make sure that your history is recorded, it is documented. Okay? If you do not know the poison, you obviously will not know what to care. All right? You can do general measures. But if the patient, for instance, has ingested something that you're not aware about, then by the time you might realize that the patient has ingested this poison, it might be too late because the poison might have already circulated in the systemic circulation and may have started damaging your organs. Okay? So, the history must be taken religiously, and most important, the identity and the amount of poison must be established as well. All right? What has been done with the lymphatic? Has there been any intervention in the house? Okay? There must be multiple sources of your history to verify. Okay? Because the danger of toxicology is the patient himself may say, no, I didn't do that. And the house companion will say, no, he did that. And there'll be conflict in the history. In toxicology, especially involving toxins with delayed onset of action, we are allowed to err on the treatment side. Because here's what's going to happen. Suppose the patient says, I took 50 tablets of paracetamol. And the house companion says, no, you did not. There are still a lot of paracetamol there, not knowing the patient bought his own supply of paracetamol. And if I believe the house companion, because the patient is a psychiatric patient, the patient could be dead in 72 hours. On the other hand, if I presume that the patient indeed took that much of poison and give the antidote is not going to be harmful to the patient anyway. So even if the patient did not take that much, the antidote is not going to do him harm anyway. So the error is towards aggressive management rather than presuming that there is no poisoning that happened. So the time of exposure, remember, there are medications that have immediate onset of action, there are poisons with delayed onset of action. The mode of exposure, was this ingested? Was this ingested? Was this injected? Was this inhaled? Etc. Has there been any exposure to other toxins? And this is where your so-called co-ingestions take place. Okay, you investigate. Wala na po bang ibang ininom? Or the patient may took a single medication, a lot of it, but you have multiple ingredients in it. Okay, like your cough medications, your cough and colds medications. It usually contain multiple medications, active ingredients inside. What are the current medications of the patient? Very important in patients who are elderly, may be demented, or patients may have problems with memory. These have to be documented because if you see a metabolic abnormality, you can take the medications of the patient, you can identify which medications, for instance, give this patient hypoglycemia. Why is the insulin depressed, etc. What's the past medical history of the patient? Has this patient been suicidal before? What is this patient's favorite suicide drug, etc. Okay? And the home remedies that must be taken. Sometimes in the panic of house companions, they may try a lot of things. They may force the patient to vomit. They may give these patients whatever it is to force them to vomit, or they may force the patient to take something else to try to neutralize the effects of the poison. Okay? Now, the timing of the ingestion and exposure has to be established. So, for instance, ethylene glycol. Ethylene glycol is antifreeze in the West. In tropical countries, we call it radiator coolant. Okay, they're the same thing. They depress the boiling point of the water, So in the West, in cold temperatures, your water inside your radiator will stay liquid even if it is, even if the temperature outside is freezing. On the other hand, in tropical countries, the boiling point of water is elevated if you're going to use ethylene glycol. So even at 100 degrees centigrade, the water inside your radiator is still be not producing steam and a lot of pressure inside. Okay, so 6 hours. Salicylates 12 hours. Paracetamol 36 hours, which means that even if the patient overdoses with a lot of paracetamol, there may be no symptoms at all over the next 24 to 36 hours. After 36 hours, only then will the patient be having nausea, vomiting, headaches, etc. But by that time, toxic effects to the liver have already set in. Paraquat is an herbicide. It's an organochlorine. It's also an agricultural pest repellent. 48 hours. Methanol. Why did I put it here? Methanol is otherwise known as ginbulan. Okay? And the problem here is that our denatured alcohol, I knew because I bought one some time ago, are also placed in exactly the same bottle where your Ginebra San Miguel is placed. Okay? So if a drunk person sees that and he thinks na bitin pa siya, he needs more, you may just simply drink it because it's in the same bottle as your commercial gin that you buy in a sanitary store. Of course, these bottles, needless to say, has to be properly labeled. All right? Methanol 48 hours. Why is it called gin bulat? Methanol, when ingested, alam nito ha, lahat ng alcohol na pumapasok sa katawan, look back to your biochemistry and your organic chemistry. Alcohols, when ingested, are converted into aldehydes by the action of your alcohol dehydrogenase. Okay? Then they are oxidized, therefore they're dehydrogenated into its organic acid. So methanol is converted into formaldehyde before it is converted to formic acid. Alcohol is converted into acetaldehyde before it is converted to acetic acid. Alright? The problem with methanol is that if it is acted upon by your alcohol dehydrogenase in the body, it is converted into formaldehyde. Unfortunately, formaldehyde has a very high affinity for the optic nerve, where it destroys your neurofibrils in there. That is why it's called gin bulat, because by the time it wakes up from drunkenness, the optic nerve will have been already irreversibly destroyed. All right? Okay. Thyroxine, as I mentioned earlier, thyroxine is a very, very long duration of action. Okay? And that's why we changing the dose of patients, for instance, who are hypothyroid. You usually wait 7 weeks to months before you decide to step up or step down. And if the patient go into overdose of thyroxine, expect the thyrotoxic effects of your thyroxine will last for 4 weeks, which means that if you're giving any antidotes and medication to slow down the heart rate, you do not discontinue that abruptly. You may have to wait 1 month before thinking of withdrawing these medications. Okay? Now, in the physical examination, in addition to toxidromes, you also examine the skin of the patient, take a look at the drugs. Is this patient IV drug abuser? Your telltale smells of your alcohol, your insecticides, your petroleum distillates, your ketoacidosis, for instance, if your patient is ingested alcohol and is diabetic, and the patient not only goes into starvation, ketosis, but diabetic ketoacidosis. Hypotension is very prominent among patients who have ingested your barbiturates, patients who have been injected botulinum toxin to the system, clonidine, ethanol, isopropyl alcohol, okay? Isopropyl alcohol ingestion, rubbing alcohol natin, will give rise to glycolic acid, okay? These are patients going to ketosis, but not elevated analytica, which is the characteristic of poisoning with isopropyl alcohol. You see hypertension also in patients who have phosphate, carbamates, and sedative poisoning. On the other hand, elevated blood pressure is characteristic of patients who use shabu, patients who are anticholinergics, cocaine, phenylpropanolamine, remember that? A decongestant, a very common decongestant we use in cough cold medications. Okay? All right. On the other hand, bradycardia is of course expected in patients who overdose with your beta blockers, your ulul generic names. Those are beta blockers. Your calcium antagonists, your thiazide, your amlodipine, your phenoldiprine, etc. Clonidine, digitalis, narcotics, and all give you bradycardia. Tachycardia, on the other hand, is seen in patients who have overdosed with substances that are very sympathomimetic in the effects of amphetamines, anticholinergics. Okay? Bakit anticholinergics may tachycardia? Kasi yung cholinergic effects mo, di ba, slows down the heart rate. So you're giving, if the patient is overdosed with anticholinergic, there's nothing to balance the sympathomimetic effect by slowing yung tone ng cholinergic nervous system. Cholinergic, the autonomic cholinergic branch of the autonomic nervous system is not balancing the sympathomimetic activity of your sympathetic nervous system. So the predominant sympathetic activity kaya tachycardia presenting. Okay? You see also tachycardia patients who are exposed to cyanide, carbon monoxide, ethanol, and ethylene glycol. Poisoning it is. Okay? I've shown you the forest before. We're now going inside the forest to show you the trees. And so I'm going through each individual. We went from toxidrome to individual symptoms or signs. Pinpoint pupils, bradycardia, hyperventilation, hyperactive bowel sounds, salivation, rhinorrhea, peculiar kerosene smell, garlic, organophosphate. These are cholinergic poisoning. You have unrelenting seizures recurring even after several dosage of diazepam, especially even if the patient is already intubated and your patient has worsening acidosis. It's very typical of isoniazid poisoning. Okay? Now, one of the simplest, the fastest way to get rid of the poison, of course, is if it is ingestion, is gastric lavage. All right? You put in an NGT to the patient's stomach and pour in water, drain it by gravity. Oh, by the way, pag nag-gastric lavage, pinapahiga ang pasyente, left lateral, trendel, and burn, head down before you start your gastric lavage. And you do not aspirate the stomach contents. You allow the gastric contents that you're, di ba maglalagay ka ng water, 100, 200 ml lang each time. Then you drain it, put it out, let it drain by gravity until you see that the return flow is clear. Okay? You might or you might not see tablet fragments if this is a tablet overdose. You may not or may not see or smell whatever chemical the patient ingested. Okay? Now take note that your gastric aspirate is most effective if the ingestion is within 1 hour. After that, either your tablets or your syrup may have already been absorbed, or much of it has already been absorbed. Okay? You do not do gastric lavage in only 2 conditions: petroleum distillates or caustic ingestion. All right? Petroleum distillates, ayaw mo pumasok ng petroleum distillates sa baga ng pasyente, ayaw mo mainihin yung petroleum distillates kasi kung di, mag-i-ARDS yan. On the other hand, sa caustics, yung mucosa is already damaged. So if you pass on, pag nilagay mo pa ng NGT, basically, the tip of the NGT will plow into your damaged esophageal mucosal injury, and that could cause massive bleeding and would further damage the mucosa. Okay? The lab examinations must be rational depending on the expected effects of the poison. Now, ordinarily, if especially in patients who we do not know exactly what they ingested, and especially the toxic effects are already coming out, in a patient who you do not know it is suicide or homicide. We want to play it safe, and so we take multiple samples. We take samples of the gastric aspirate, we take samples of the urine for toxicology studies, we take samples of the blood, both heparinized and clotted blood. Okay? And this we keep in the freezer, or refrigerator, by the freezer, by the refrigerator, for further studies if need be. Okay. Here's your so-called eto muna. The timing of the blood draw might be essential, especially in patients who have paracetamol or acetaminophen overdose. Okay? The best time to take your blood examination for paracetamol assay is 4 hours post-ingestion. Why? Because that's the highest level, that's the time where your paracetamol will peak in the blood. And so in that respect, using your so-called Matthew Rumack nomogram, you'll be able to predict whether this patient liver is going to burn or will be safe. Okay? And so that's the usual, the brown line, the brown line in the middle will tell you above that line, there's a high risk of hepatotoxicity. Below that line, not likely. And so if the patient is in the green zone, then you may not need to give your antidote. On the other hand, if your patient is towards the red line, you might have to start your antidote. Antidote for paracetamol poisoning, of course, is your acetylcysteine. Okay? Okay, prevent further exposure, decontaminate the patient. If the patient, for instance, had splashed malathion on his shirt after vomiting, after ingesting a cup full of it, then you have to remove this, all right? You have to remove the clothes of the patient. Emesis induction, which we usually do in children, especially if the ingestion is witnessed, all right? Other than that, we do gastric lavage in the emergency room. We want to prevent further absorption, so if the patient that ingested, let's say, an excessive amount of tablets after gastric lavage, when you put in your activated charcoal, where the activated charcoal will adsorb, or rather, the poison, the toxin will be adsorbed to the surface of the activated charcoal, and since it will no longer be absorbed from the intestine of the patient, is going to pass this out. In certain instances where you may need to rapidly make sure that the poison does not get absorbed. We're talking of illicit drugs. We're talking of drugs that are wrapped in condoms, in plastic sachets, which you usually see in couriers in the airport, legal drug trade, or patients who are taken expanded release or coated iron sulfate. We're talking pregnant women. Okay, you know that iron overdose in the liver can give you hemosiderosis. It could even kill the liver as well. And if we do chest X, if we do abdominal X-ray, for instance, and we see these tablets still intact in the intestines of the patient, or these illicit packets of drugs that have been tested, we do hold our obligation. In addition to gastric lavage, we do enema the patient until the return flow is clear or until all the tablets will come out. In addition to the cathartic that we give the patient to accelerate peristaltic movement in the intestine. Okay? And of course, if the poison has already reached the systemic circulation, you're going to have to give your antidotes. All right? Patients whose skin is contaminated. We're talking of patients who have been splashed themselves with caustics. We're talking of liquid salsa, sodium hydroxide, concentrated nitric acid, concentrated hydrochloric acid, even muriatic acid or sulfuric acid. The clothes of this patient has to be taken off and the skin has to be rinsed repeatedly. Okay? If there's been contamination of the eye, all you have to do is put the eye under running water and let it run for at least 30 minutes, especially if it is caustic alkali. All right? Again, if you're helping nursing aid get rid of this contaminated skin or clothes, you must be wearing protective gloves. Right? Home medication, don't try this at home, guys. Apium viburnose to induce vomiting. We usually use this to children, okay? And there's no reason why you should not rush the kid to the hospital. But then again, just in case you're in a remote area where you have no access, apium viburnose is kitchai. You pound that, you extract the juice, give that to the patient. That's a very efficient emetic. Okay? Now, Epicat is virtually not used anymore. All right? But if you have it, you can use it and you can repeat the dose just once. We do not routinely use it, especially in adults, because emetine is, which is the active ingredient in syrup of Epicat, is cardiotoxic. So in the elderly, we do not even think of trying it. Okay? We do not induce vomiting in patients with decreasing sodium. Aspiration pneumonia is very high. Patients who have been gag, patients with late pregnancy, patient can go to the ARDS. If the patient has ingested caustics, hydrocarbons with open petroleum distillates, convulsants, and hypogenic agents do not induce vomiting. The vasovagal reflex can cause cardiac stasis, okay? Which is also true in patients with no cardiac disease or aneurysms. Of course, kung aneurysm, susukan pasyente mo. Sumabog yung aneurysm na yan, wala patay ka agad yung pasyente niya. Alright? So gastric lavage, it may be beneficial even as long as 6 to 12 hours after ingestion if the known toxin delays gastric emptying. We're talking of ingestion of tricyclic antidepressant, salicylates, opiates. Okay? If the patient comes in, let's say 6 to 7 hours after post-ingestion, 6 to 7 hours post-ingestion, you probably can still run after the poison ingestion in the stomach using the gastric lavage. I've told you this before. You insert your NJP, large 4, place the patient left lateral Trendelenburg, and pump in 50 to 200 ml. Let it fall below the patient's body, let it drain by gravity. Do it again repeatedly until the third flow is clear. Okay? Now, if you're still worried of whatever remained in the tested the patient, you can follow that with activated charcoal. Okay? The remains in there, small intestine, you should bind to your activated charcoal and be excreted harmlessly. Okay? You do not do gastric lavage in patients who have ingested caustics regardless whether it's acid or alkali. We do not do gastric lavage in patients who have ingested petroleum distillates. We're talking patients na lumaklak ng gas, gasolina, diesel, etc. Okay? And patients who are actively sneezing. All right. Most emergency departments would usually not allow this because of the discomfort, but then it still would be very, very helpful, especially if the patient has a toxic ingestion in the past hour, because you know that the toxins, the tablets are still in the stomach. All right? Now, kasi nga daw, hindi naman lulusot yung tableta sa laki ng GT. The problem is, the argument is probably valid theoretically, but you see, tablets, even your intercoated and your extended release medications, once they get in contact with the gastric secretions, they start breaking down. All right, they may not break down completely, but because they're following the concept that extended release, dapat intercoated, dapat. So the rest of the medication may be released into the small intestine. However, most manufacturers will see to it that while their product has an extended duration of action, they also see to it that it will have its effect immediately, which means part of the tablet, of the product, of the capsule will start dissolving in the stomach and get absorbed. So the therapeutic effect will immediately be exerted, even as the rest will be released in the small intestine, where it may sustain the expected or the therapeutic effect expected in a particular drug. Okay? And again, we're in a low resource country, so yes, we still do it, especially, but provided the ingestion is quite recent. All right? So how about your activated charcoal lavage? You may do it initially. In other words, instead of just plain saline, you may use your activated charcoal to maximize absorption of the toxin into the activated charcoal, therefore removal of whatever offending toxin there may be in the stomach. Okay? And usually the golden rule is 10 to 1 ratio of the known dose of the poison of the toxicant times 10 that's the volume of activated charcoal required to use. You usually suspend the activated charcoal. Activated charcoal comes in powder form, so it's non-soluble, so you have to suspend it in either water, and in juice, in cola, nakakadiri na naman tingnan. Patients, there are some cooperating patients from stress. Who may drink it by straw. The suspension of activated charcoal. Uling kaya yan. And patients whose ingestion will be from drugs or medications that undergo intrahepatic circulation, repeated doses will be done every 4 hours until the patient passes out the activated charcoal. Then you know the patient has already passed out, has also passed out the ingested poison. Okay? You do not do that also in patients who have ingested caustics, petroleum distillates, and patients who have ingested substances that cannot be absorbed into the activated charcoal. We're talking alcohol, cyanide, iron, lithium. So again, gamit ng lithium sa mga bipolar. Alright? Ito pwede yung paggamitan ng repeated dose of activated charcoal. And these are, I think I have also listed. Okay, these are the things that you can use your activated charcoal on a single dose or repeatedly. Okay? In the previous years, especially during New Year, yung Watusi, dancing firecrackers tawag ko sa English. Children as young as 3, 4, 5, because this is usually come in different colors, attractive neon colors, orange, red, green. Yung mga hindi gamit o yung mga pupul na Watusi, you would usually ingest it. Now, Watusi contains the form of phosphorus which burns even with a slightest friction, and it also burns if exposed to acid. That's why even if the manure in the gastric mucosa is wet, when the phosphorus in the dancing firecrackers get in contact with the acid, it can still explode, it can still burn. So the egg whites here basically forms the protein in the egg whites to sacrifice itself so that the stomach mucosa is protected from the erosive, explosive effect of your Watusi. Okay? Now, sodium bicarbonate diet poisoning, apparently it transforms the ferrous sulfate into ferric, which is non-absorbable, but that is being contested. You know that one of the tests for the presence of iodine is exposing it to carbohydrates because that forms an insoluble blue to blue black complex. And so in patients may have overdose with iodine solution, concentrated iodine, which you find in the laboratories, which some surgeons may still advise for the patients to take just before surgery to make the thyroid less vascular. Some patients can overdose, ingest that, and the very first thing you want to do is to give this patient nothing but a starch slurry. Okay? When you go, the idea is to have the iodine bind to the carbohydrate so it doesn't get absorbed. Okay? Strychnine, quinine, nicotine poisoning, we rarely see that anymore. All right. And then after your gastric lavage, you activate your charcoal, may give you cathartics. Basically, you want the peristaltic movement to hurry up, to accelerate the evacuation of what the intestinal contents so that absorption may be mitigated. And if this patient is on activated charcoal, you want to make sure that whatever it is the patient has ingested is passed out with the activated charcoal. Okay? Um, Cathartics may be in the form of sodium sulfate or polyethylene glycol, your glycolide, your goldite, these are polyethylene glycol, okay? Or anything that you can get your hands on. Magnesium citrate. These are these are um, these are cathartics that your radiologist may use, especially if they're preparing patient for GI series or lower GI series, okay, to clean the intestines. Now, in worst case scenario, we may use WBI or whole bowel irrigation. When you do catharsis of the flow is clear. And when you continue giving catharsis, you may do enema in this patient until one, the patient is passing out nothing but clear water, or if the patient has ingested illicit drugs, until all the illicit drugs have been passed out by the patient. All right? Forced diuresis. This is less indicated because most drugs are metabolized by the liver. Okay? Others may impair the cardiorespiratory function. And in patients who may have poison, may overdose with barbiturates, amphetamines, salicylates, you might have to use this. These are, of course, agents that are excreted or eliminated to the kidneys. You want to accelerate this by forcing the patient to go, by giving them diuresis. And so this patient must have to excrete this several times in large volumes with the toxic ingredient carried out in the urine outside of the body. All right? We usually use 20% mannitol, but if the patient is in pulmonary edema, we use furosemide instead. All right? Now, in addition to forced diuresis, we may alkalinize the urine to make sure that we achieve a particular result. In patients with rhabdomyolysis, for instance, saan ka nagkakaroon ng rhabdomyolysis? Patients who are going to intractable seizure, patients who are going to status epilepticus, patients who are victims of hazing, severe bleeding, for instance. There will be a lot of myelonecrosis, lot of rupture of your muscle cells. This would release not only potassium, but myoglobins into the blood. Now, myoglobins in acid milieu tend to stay in, will stay as a large molecule, undissolved in circulation. Now, when they reach the kidneys, they could block the tubules. So what we do, we keep the urine pH on the alkaline side to make sure that your myoglobin remains in solution and they do not precipitate. Otherwise, when they block the renal tubules, your patient can go to acute renal shutdown, and the patient may have to end up in dialysis. Okay? On the other hand, you may acidify the urine, and we do this in patients who may have overdosed with amphetamines, PCP, or phenytoin. In this case, we use your ascorbic acid, vitamin C. We don't use ammonium chloride anymore. All right? And of course, failing that, we use dialysis or hemoperfusion. What do we do basically? Basically, dialysis or hemoperfusion uses a special filter. The blood is passed through there. Whatever unneeded ingredients are filtered out before the blood is returned to the body. That's hemoperfusion, that's dialysis. What's the difference? The filters that are being used. Okay? So, in patients where you use hemoperfusion, these are the things that we cannot subject them to hemoperfusion, hemodialysis wise. If the ingestion, for instance, is highly protein bound, okay, already fatal, young before they get the benzodiazepine or antagonist, they can depress the respiration. But again, if it is a single ingredient intake poisoning, no congestions with the benzodiazepine, it's really fatal. Okay? If the patient's ingestion of the drug has a large volume of distribution, like phenothiazis, this antipsychotics, or if it has irreversible action, huwag ka na mag-dialysis kasi kung masyado mataas ang ingest ng cyanide ng pasyente, you may artificially prolonging the life. The patient may be in a ventilator, the patient may be in inotropes, but that brain is not going to recover back to what it was before. So forget it. How dangerous as outrage it is if the patient, for instance, is hypotensive. Even among patients who are on routine dialysis, they have their blood pressure taken at baseline. Because if the patient is hypotensive to start with, the initial draw of blood into the hemodialysis machine definitely give you hypotension. And the problem is if the heart is not able to handle that, the patient can go to cardiac arrest in dialysis. All right? Regardless of condition, if the patient has ingested this, Amanita phyloides, these are poisonous mushrooms, ethylene glycol, depending on the volume, the manifestation of the patient, methanol. Remember, methanol kasi has high affinity to your optic nerve, huwag ka lang mag-antay for 8 hours kasi once sabihin ng pasyente, hindi na makakita, you cannot reverse the process anymore. Heavy metals, provided you chelate first, we're talking lead, arsenic, antimony, mercury, etc. Okay? And sometimes, depending on how fast we want the patient to be detoxified, alcohol, ammonia, aniline, isoniazid, amphetamines, all these things listed. We have to have the patient undergo dialysis or perfusion, especially for patients who take lithium. All right? As the lithium is much smaller than sodium or potassium, so that even if you force the patient to diuresis, mauunang lalabas ang sodium and potassium. That's why you need hemodialysis to get treated to access lithium in the patient's body. Just take a screenshot of this. These are just too many for me to be able to go through that one by one. All right. So dialysis is especially effective on patients who may have ingested methanol, ethylene glycol, and the idea is to prevent this from forming, for increasing the formation of highly toxic organic acids. We're talking formic acid, glycolic acid. So even as your formaldehyde and your glycolic acid, even if your formaldehyde is very toxic to the optic nerve, your glycolic acid is walang mapapasukan sa pathway kasi natin, katawan natin. Wala sa Krebs cycle ang tatanggap ng glycolic acid. Okay? As I mentioned earlier, isopropyl alcohol toxic ingestion leads to ketosis. If a patient will have peculiar ketone breaths, like in DKA. However, in DKA, you have an increase on iron gap. In patients with isopropyl alcohol ingestion ketosis, the iron gap becomes small. Okay? This I mentioned the alcohol aldehyde organic acid sequence. Okay? Now, in patients who have ingested methanol or ethylene glycol, we do not have fomepizole in the country. Or if it is present, napakahirapan natin. So what do? We use ethanol. Okay? The idea is to try to competitively inhibit your methanol and your to competitively prevent your your isopropyl alcohol, your ethylene glycol, and your methanol to be acted upon by your alcohol dehydrogenase. Okay? So the result is that instead of producing a lot of formic acid, glycolic acid, formaldehyde, your patient is going to be producing a lot of acetic acid, acetaldehyde, which can enter your Krebs cycle anyway. All right? So less toxic compounds are being formed. Cofactors are also provided, such as your folinic acid, Folic acid or euphorbic is also given in patients with methanol toxicity, and of course, tetrodotoxin and thiamine if the patient has had antifreeze or JPEG coolant poisoning. The reason for that is you want to supply, make sure that the cofactors that break down these alcohols are adequate in the body. Otherwise, the administration of the ethanol would be useless. All right. Finally, we have your antidotes, and antidotes come in different forms. You may have antidotes that prevent further absorption to the systemic circulation by forming inner complex formation. Classic example are your chelating agents. All right. So, for instance, in arsenic, the dimercaprol, or your dimethylpropane sulfonate, otherwise known as BAL or British antiluminoside, is what we use for arsenic exposure. Mercury, BAL, or dimethyl, dimercaptosuccinate or dimercaptosuccinic acid. For patients who are exposed to lead, you either use ENTA or dimercaptosuccinate, copper, penicillamine, iron, diferoxamine. Masarap basahin, ano? Ang hirap hanapin yan dito sa Pilipinas. Kaya sa mga pasyente na nag-overdose ng iron, we may have to force ourselves to give the patient whole bowel irrigation. Okay? Or we may accelerate the detoxification. Traditionally, in patients with cyanide exposure, kung hindi naman, kung subfatal o sublethal ang exposure, then we give the patient nitrate, then thiosulfate. The idea is to convert your cyanide into thiocyanate para hindi, para so the cyanide portion of the patient will be stopped. Okay? Theoretically, it is good, but because of the rapid action of cyanide, if the patient ingests cyanide, within 5-10 minutes, the patient would usually be dead. All right? So now, in other countries, you have your cyanide kit containing hydroxycobalamin. Basically, if the patient ingests cyanide, you just inject this, and the idea is your cyanide is converted into cyanocobalamin, which is passed out through the urine, and so the patient will be okay. Now, in the Philippines, in tropical countries, there are also sources of cyanide, which you may not be aware about. Cassava. Cassava contains cyanoglycosides. And so is your nabog, bamboo shoots, which is a delicacy locally here, especially in Managata. These cyanoglycosides, when exposed to heat, gets destroyed. Okay, and your cyanide is converted to cyanates or compounds with other carbohydrates. The idea is that this has to be cooked very well. They must be boiled for at least 10 minutes before you can get rid and render your cyanoglycosides non-poisonous. Otherwise, during exposure to air, cyanoglycosides can produce cyanides and other complex glycosides, which is very poisonous. Okay? So, what do? Simply boil it out. During boiling, your hydrogen cyanide, which is clean from the cyanoglycosides, is vented out into the atmosphere. Alright? So obviously, huwag mong ambition yung magpastig doon sa pinapakuluan mong lamog o kasama. Okay. And at one time or the other, imported Chinese jewelry cleaners contain a lot of cyanide as well. That's why I think 3 years ago, the Department of Health have demanded that these be recalled and be returned and no longer the import permits of these products be revoked because they contain cyanide and a few ingestions have proven fatal. Okay? Antidotes may also be in the form of reduction or conversion to more toxic compounds. Reduction of the more toxic compounds. As I mentioned, ethanol is being used, as an antidote for methanol, ethylene glycol, even isopropyl alcohol intoxication. Okay? Because if you give your alcohol dehydrogenase, as I mentioned, instead of formic acid, glycolic acid, uh, you convert the action of your alcohol dehydrogenase will be predominantly ethanol, the byproduct of which can enter the biochemical pathway of the body. Unlike the byproducts of your isopropyl alcohol, methanol, and your ethylene glycol. Okay. Also, we use the use of acetylcysteine to prevent conversion of paracetamol to NAPK or your N-acetyl benzoquinonimine. Your benzoquinonimine is the one that kills the hepatocytes in patients with paracetamol overdose. So what does acetylcysteine do? Your acetylcysteine, basically your NAPK consumes the glutathione, that's the one that breaks down your paracetamol. And if you have accumulation of unapine, that's the very toxic substance, the byproduct of paracetamol that is extremely hepatotoxic. So the answer to paracetamol toxicity, paracetamol poisoning, paracetamol overdose is to make sure that the body has enough glutathione to break down napkin. Okay? How do you do that? Your acetylcysteine is your cysteine donor. So that if it combines with glutamic acid, your glutathione is regenerated, and so the byproduct NAPK is converted into glutamate and urea, which is excreted through the urine. Okay? You may have competitive inhibition at receptor sites like the use of your naloxone in patients with overdose of opioids, and atropine versus acetylcholine in patients with organophosphate or carbamate poisoning. Yung drug of choice sa organophosphate poisoning is actually pralidoxime and oxide. Unfortunately, wala pa rin makita niyan sa Pilipinas. So what did you do? We block your organophosphate at the acetylcholine site by giving atropine. Kasi pag nakaharang yung organophosphate doon sa cholinesterase mo, lala kung kukumpulsyon yung pasyente mo katakot-takot. Okay? As I mentioned earlier, the household insecticides we have that contain a lot of carbonates before have now been replaced by pyrethrin derivatives. And as I mentioned, its neurotoxicity to insects is 1,250 times more than mammals. So in very small amounts, when you spray it, it's not probably going to kill you. It's not going to give you any toxic effects unless you're severely allergic to your pyrethroids. Pyrethroids, as I mentioned earlier, are alkaloid extracts of chrysanthemum, which has been found to be very potent insecticides. To make bypass the poison effect, okay, like against your ethylene cyanide, you give thiosulfate so that your thiosulfate is sodium nitrate so that your cyanide is converted into thiocyanate, which can easily be excreted by the body without paralyzing your electron transport chain. All right. Among patients who overdose with isoniazid, you have a lot of GABA synthesis put on hold, and so these patients will have no inhibiting walang inhibitor sa cerebral transmission ng nervous stimuli kaya kumbulsyon ng pasyente. Your GABA is neural inhibitory, right? So it is exhausted because of your ironase, because of the consumption of your pyridoxal in the brain, then you don't have GABA. The administration of pyridoxine reinitiates the synthesis of GABA, which is neuroinhibitory, and that's the reason why you sure would stop if you have enough pyridoxine, even if the patient has taken a lot of isoniazid. Glucagon is also used among patients with overdose with beta blocker in a separate pathway, right? Because your beta blocker, if you remember your pharmacology, has negative inotropic, negative chronotropic effect. In other words, babagsak ang blood pressure, babagal ang heart rate ng pasyente. Glucagon stimulates or opposes this action in a different manner. It does not involve receptors, okay? So your AV conduction is improved, and your the force of contraction also improves, but not in the same pathway as your beta blocker. So hindi siya competitive inhibitor, but an independent pathway. Okay? Kasi before, pag beta blocker, hindi mo naman pwedeng bigyan ng inotropic like yung epinephrine kasi haharangan din naman yun. Plus, the alpha effects of your epinephrine may cause more severe tachycardia. Alright? Kaya imbis na gano'n, glucagon binibigay because it increases, it brings up the heart rate and it also strengthens the contraction of the heart in a separate manner. Okay. You may have antibodies versus poisons. You know that, for instance, your inflammation always requires an antivenin, and patients who overdose with digitalis. Yes, we still have patients who are digitalis. You have your F fragment antibodies against digoxin. Okay? Now, I think this is the last topic, caustic acid, caustic acid, sulfuric, organic, nitric, concentrated acids, and others. The toxicity is related to how low the pH, the concentration of the contact pad. Now, exposure to caustic acids, sulfuric acid, nitric acids, nitric acid is being used by jewelers, sulfuric acid are very common in mocha shops. And muriatic acid is lying around in most of our houses kasi mga mains natin, kasabay natin, tinatamad mag-is. Yung tiles, bubuhusan na ng muriatic acid. Don't let them do that, please. Vinegar will do the same job anyway. Okay? If the mucosa is exposed to concentrated acid with low pH, you have coagulation necrosis leading to perforation and peritonitis. And during the healing process, you can have stenosis, stricture, etc. All right? So what do you do? If the patient ingests a caustic acid, you do not insert the NGT. If you have to insert something inside the stomach, because eventually lalagyan mo rin naman kasi paano pakakainin ng pasyente. Paano kailangan i-bypass ang stomach dahil sunog na sunog, kailangan ibigay pagkain sa small intestine. You may insert the tube provided it is under direct vision. Okay? Otherwise, nag-coagulate necrosis na nilagyan mo pa ng tubo na kuko. It's just like, it's like pushing a knife into a wet paper towel. Now, it's more dangerous with this caustic acid because caustic acid destroys tissues by coagulative necrosis. For the same concentration, mas destructive ang caustic alkali. We're talking drain cleaner, liquid sauce ninyo. Bakit? When you have coagulative necrosis, the mucosa is transformed basically to what looks like a gelatin. Very malabsa na gelatin. So imagine doing that, putting an NGT and plowing through the gelatinous mass because of the coagulative necrosis. The problem also is that for as long as the coagulative necrosis is there, your caustic alkali can still penetrate the deeper layer. On the other hand, on caustic acid, you have your coagulative necrosis. Your coagulative necrosis tissue serves as a barrier against further destruction. So between the same concentration of your caustics, one is acid, the other is alkali, your caustic alkali is much more destructive. All right? And the problem here is that you cannot reverse that. Hindi ka pwede magbigay ng antacid kung ingest ng pasyente ng muriatic acid. You don't. That will give you a very a very exergonic reaction that will release a lot of heat. So in place of not only going to cause chemical burns, you will also give your patient thermal burns. You do not give neutralizing agents, especially caustic acids. Why? The adjacent secretion of bicarbonate to the small intestine can generate a lot of carbon dioxide. Pwede yung lumobo, siguro ang pasyente mo, sasabog yan sa sobrang dami ng carbon dioxide na accumulate. Okay? And then if you take a look at the after effects, the injury that we have with caustic acid can have a scar formation, and you may have. And the problem is there's nothing much you can do once the mucosa has been destroyed. You just wait for it to heal. Unfortunately, you may have a lot of scar formation, you may have a lot of constriction, and you may have to have a lot of repairs. All right. Again, yung caustic alkali, we're talking sodium hydroxide, sodium carbonate, potassium hydroxide, ammonia. Yung pinagpupulot sa pano ng pagkasakit-sakit sa ilong o concentrated caustic alkali. Alright? Alright. Again, to the same molar strength, concentration, mas destructive ang caustic alkali. Okay? And look at this. The chemical burst of the caustic alkali could go deeper. It can even reach the mediastinum, the pleura, the peritoneum. Alright? What can you do? Antibiotics lang and cortisone. And a lot of prayers that the damage does not progress any further. Because once your mediastinum is reached, chances are next will be the heart, and that's it. I think this is from your Harrison. Just go back to it. It's 2 minutes before 5. I think we can stop here. Just take a screenshot of these two. This is the summary of the basic principles of toxicology and how to address patients with poisoning. This is on the management side, okay? And this one, I think this one is from your Harrison. All right? Are there any questions? Concerns? Taga may chat. Oh, okay. You're supposed to evaluate me after this lecture. Are there any questions? Lala? No questions at all? Nakatulog na kayo lahat? Hello? Anybody still there? If there are no questions, let's call it a day. Good afternoon, everyone.
Thank you, Doc.